Welcome to Drugs in Dermatology. In this video, we will be discussing the current FDA-approved anti-interleukin-12, interleukin-23 agents relevant to dermatology. Currently, there is only one treatment that falls into this class, Ustekinumab, known as Stelara. Although there are biologics for interleukin-23 exclusively, we will talk about those in a separate video. An important note is although this class of drugs may be utilized for a wide range of treatments, we will be looking through a dermatology lens focusing on dermatological diseases that are FDA approved. So, let's break it down. Drugs in dermatology style. Ustekinumab, marketed as Stelara and developed by Janssen, is a fully human IgG1 monoclonal antibody administered subcutaneously that targets the P40 subunit shared by both interleukin-12 and interleukin-23. In dermatology, its primary use is in the treatment of psoriasis. What makes Ustekinumab clinically exciting beyond its efficacy is its dosing convenience. Following induction doses at weeks 0 and 4, it is administered every 12 weeks during maintenance, which is the longest standard dosing interval among the biologic agents approved for psoriasis at the time of its development. This 12-week schedule was a meaningful quality of life advantage for patients and contributed substantially to its early adoption. Although the drug neutralizes both interleukin-12 and interleukin-23, its therapeutic effect in psoriasis is considered to be primarily mediated through interleukin-23 inhibition, which suppresses the Th17 inflammatory pathway, the dominant driver of psoriatic inflammation. This mechanistic understanding eventually led to the development of the selective interleukin-23 inhibitors, which target only the P19 subunit of interleukin-23, sparing interleukin-12. You can think of Ustekinumab as representing a transitional agent in the evolution of biologic therapy for psoriasis. More selective than the anti-TNF agents that preceded it, and eventually superseded by a more selective class of agents. Ustekinumab was developed by Janssen Biotech, which is a Johnson & Johnson subsidiary. On September 25, 2009, Ustekinumab received its first FDA approval for moderate to severe plaque psoriasis in adults who are candidates for phototherapy or systemic therapy. This approval was based on the Phoenix 1 and Phoenix 2 trials. In September 2013, the FDA approved Ustekinumab for active psoriatic arthritis in adults, supported by the P-Summit 1 and P-Summit 2 trials. In October 2017, the FDA approved Ustekinumab for adolescents aged 12 to 17 years with moderate to severe plaque psoriasis, based on the CADMIS trial. In 2020, the pediatric psoriasis indication was further expanded to include children aged 6 to 11 years, based on the CADMIS Junior study. The drug Ustekinumab holds two FDA-approved dermatologic indications. The first is moderate to severe plaque psoriasis in patients aged 6 years and older. AAD and National Psoriasis Foundation guidelines also support its use across specific psoriasis subtypes, including palmar-plantar, nail, scalp, pustular, and erythrodermic psoriasis. The second is active psoriatic arthritis in patients aged 6 years and older. As seen, Ustekinumab binds with high specificity to the P40 protein subunit, shared by both interleukin-12 and interleukin-23. preventing these cytokines interacting with the interleukin-12 receptor beta-1 receptor chain on the surface of immune cells. The two cytokines it blocks have distinct but complementary roles in immune regulation. Interleukin-12 promotes Th1 cell differentiation and natural killer cell activation. Interleukin-23 is the primary regulator of Th17 cell differentiation and maintenance. It drives Th17 cells to produce cytokines which stimulate keratinocyte hyperproliferation, recruit neutrophils, and sustain the chronic inflammation of psoriasis. It is this interleukin-23 Th17 axis that is considered the primary therapeutic target in psoriatic disease, and blocking interleukin-23 is understood to be the primary driver of Ustekinumab's clinical efficacy in psoriasis. This drug's overall safety profile is favorable. The most common adverse effects are nasopharyngitis, upper respiratory tract infections, headache, and fatigue. Less commonly, back pain, dizziness, injection site erythema, myalgia, and depression have been reported. Major adverse effects include serious infections such as cellulitis, pneumonia, diverticulitis, sepsis, osteomyelitis, and herpes zoster. Regarding malignancy, post-marketing reports have identified cases of rapid onset cutaneous squamous cell carcinoma, particularly in patients with pre-existing risk factors such as UVA exposure, prolonged immunosuppression, or over 60 years of age. Serious hypersensitivity reactions, including anaphylaxis and angioedema, have been reported. Non-infectious pneumonia, including interstitial, eosinophilic, and cryptogenic organizing pneumonia, have been reported in the post-market setting. Paradoxical skin reactions have also been documented, including pustular psoriasis, erythrodermic psoriasis, and hypersensitivity vasculitis. The only absolute contraindication to Ustekinumab is hypersensitivity to the drug or any excipients in the formulation. Ustekinumab should not be initiated during any clinically important active infections and should be discontinued if a serious infection develops during treatment. Live vaccines should be avoided, and age-appropriate vaccinations should be completed before initiation. Pre-treatment TB screening is mandatory, and latent TB must be treated before initiating Ustekinumab. As always, we will close our video with a table going over the main talking points. I hope you have a better understanding of anti-interleukin-12, interleukin-23 therapies. This is meant for educational and informational purposes only, and should not be used as a substitute for medical advice, diagnosis, or treatment. Thank you for watching, and see you in the next video.